very commonly in clinics. And we'll be hearing a lot today. We will have two presenters from that center. Will start. He'll be taking us on the relevant anatomy, the pathophysiology, and clinical manifestation of CSM, that's cervical spondylotic myelopathy. After that, we are going to have Dr. Chukuma. Please, I would want at the moment, please, everyone mute your devices for now. Thank you. Next will be Dr. Chukuma Hilary, also a fourth-year neurosurgery resident at UNTH Enugu, and he will be taking us on the management of CSM. Each presenter has 25 minutes, and I will be the accurate timekeeper. Thank you. After that, we'll take some questions, and then we would listen to our guest faculty today, whom we will introduce at that time. So without taking too much of our time, this is 4 minutes after 4. Let us have our first presenter for today, Dr. Aka Chibike. Please, you have 25 minutes.
Thank you so much, Dr. Opara. Good evening, Prof. Good evening, other trainers here present. Good evening, senior colleagues and other colleagues here present. My name is Dr. Ka. I'll be taking the pathophysiology, the relevant anatomy, pathophysiology, and clinical features of this condition, cervical spondylosis. Cervical spondylosis is a result of disc degeneration. Cervical pathologies, which result in structural changes in the intervertebral disc, facet joints, and oncovertebral joints, may compress neural structures. So understanding the spinal biomechanics and these pathologic processes is critical to management decision-making in symptomatic patients. The changes that occur, usually as we age, our cervical spines will eventually degenerate. However, increase in mechanical loading and other stressors can actually accentuate this condition. Additional risk factors like smoking, genetic predisposition, localized trauma, infection can also accelerate these degenerative changes. These concepts, spondylosis, cervical spondylosis, actually is a wide spectrum of different conditions, ranging from congenital spinal stenosis, altered mobility, fusion, and hypermobility of adjacent segments, and abnormalities in the changes in the lordotic curvature of the cervical spine, and hypertrophy of associated ligamentous structures like lamina, facet, and dura. And even degeneration of the intervertebral discs have all been described as part of this spectrum of cervical spondylosis. Next slide. This condition accounts for about 2% of hospital admissions in the US and is been found to be the most frequent cause of spinal cord dysfunction in those that are greater than 5 years. Cervical spondylotic myelopathy is quite rare in people that are less than 40 years. A Ghanaian study actually found out that those that carry heavy loads in their head have an increased risk of having cervical spondylosis. And these findings have also been replicated in other studies, in local studies in our country. A Chinese study pegged the prevalence of this condition at 13.76%. It's also, this condition accounts for 28.6% of all cases of spondylosis, and is second to only lumbar spondylosis. A local study showed that it accounts for about 5.4% of clinic visits, in neurosurgery clinic visits, and 10.7% cases of 10.7% of all cases of rheumatology. Next slide, sir. The natural history of this condition is quite unpredictable, and studies have shown that nearly 75% of cases of cervical spondylotic myelopathy will progress, and out of this, a third of it will progress in a rapid fashion, while the remaining 2/3 of this 75% will progress gradually. Although there are studies that have tried to refute this. Next slide, sir. For the relevant anatomy, we will see from the slides that the cervical spine consists of about seven spines, 2 atypical spines, the first cervical vertebra, and the second cervical vertebra, the atlas and the axis. And then the remaining 5 are actually typical, although the 7th cervical vertebra has a marked identifying feature. So looking at these slides, we'll notice that there is a central neural foramen, which is the spine goes down. As you go down the spine, it gradually decreases in the width. This actually houses the spinal cord, and the vertebra has both anterior and posterior arches, especially the first cervical vertebra, and the posterior arch is marked by a spinous web, which is not prominent in the upper cervical vertebra, but for the 6th and the 7th, particularly the 7th cervical vertebra, which has been called the vertebral prominent, is quite prominent and can be used to identify it in on table. The 2nd cervical vertebra is marked by a body that is on top of its vertebral body, which is the odontoid process, which has been described as the mixed body of the atlas. At its lateral mass, it has foramen that admits vertebral arteries on both sides as they originate from the thorax and head into the intracranial cavity. Next slide, sir. Next slide. Next slide. So this shows actually anterior and posterior accesses. This shows the anterior and posterior accesses through this cervical spine, the anterior approach for ACDF and other procedures, and then for the posterior access to the midline, which allows access for maybe lateral muscle insertion or even for laminectomy. So it shows that during that access, it's one on the carotid sheath and its structures can be retracted laterally once more access is gained through the skin, subcutaneous tissue, through the platysmos muscle, and then down to the pretracheal fascia. So, and then on the medially, it can be retracted. The trachea and the esophagus can be retracted medially. Next slide, sir. It's important to note that the normal cervical spine diameter is 18 millimeter anterior posteriorly, and the normal cervical spinal cord diameter is 10 millimeter. So it's been found that when there's a decrease in 30% of this diameter, symptoms begin to manifest. So patient may start having cervical spondylotic myelopathy. Next slide, sir. By reason of pathology, as the intervertebral disc ages, they fragment, dehydrate, and collapse. It's important to know that these changes actually start at the nucleus pulposus, resulting in central annular lamellar buckling in while the external concentric bands of the annulus fibrosus bulge outwards. This causes an increased mechanical stress. Next slide. At the cartilaginous end plates. With increased axial loading, it alters the cellular composition of the nucleus pulposus with a decrease in the hydrophilic proteoglycans and increase in collagen type 2, 3, 6, and 9, as reported by Urban and his colleagues in 2000. The mechanical properties of this disc progressively changes the intervertebral disc height, which is reduced, and eventually cracks and fissures appear in the annulus and the vertebral end plates, leading to nucleus pulposus herniation. Next slide. This altered stress does not only affect this part, but also equally affects the facet joints, with making them to be segmentally hypermobile, with osteophytic spores deposited, which is actually an adaptive process in a bid to remodel and increase stability of the facet joints. There's also subpedostal bone formation, which has been described, which gives rise to osteophytic bars, which may further narrow the canal. As the ventral osteophyte develops and the cervical suppository becomes narrowed, This also stabilizes the adjacent vertebra, which are hypermobile as a result of the lost disc material. Furthermore, the unsnare process may become hypertrophic, leading to also compression of the exit nerve root foramina. Next slide. Next slide. So this diagram actually shows this diagram actually shows, you know, the osteophytic bars with the arrows, the red arrows, which is narrowing the cervical, the canal, the neural canal. And then next slide. And then there's also the unsnare process, which is showing unsnare process hypertrophy, which is showing narrowing through which the exits as for the exit nerve root, which can also be a source of pain like radiculopathy in these patients. Next slide. The surrounding ligaments are not spared. These ligaments may become hypertrophic and may even undergo hyperplasia or there may be hyperplasia of the non-fibrous cartilage and capillary hyperplasia as reported by Inamasu in 2006. The changes may also occur in the bone with straightening of the normal cervical lordosis, and patients may even adopt a kyphotic or hyperlordotic or sclerotic deformities. Next slide. This spondylotic myelopathy can occur through a number of pathophysiologic processes, and this include the static mechanical, the dynamic mechanical, the spinal cord ischemia, and stretch-associated injuries. The static compression actually causes just direct trauma to the spinal cord as there's increase in narrowing, and this can be a source of a chronic cord ischemia. While the dynamic processes may arise from translational movement of more than 3.5 millimeter, these dynamic factors actually occur in such a way that during normal flexion and extension, so that during normal flexion, the spinal cord lengthens, resulting in it being stretched over a ventral osteophytic bar. While during extension, the ligamentum flavum comes into play as they may buckle into the cord, pinching the cord between the ligaments and the anterior osteophytes. The spinal cord ischemia has also been found to play a role in the pathophysiology of cervical spondylotic myelopathy. This is because histologic changes that are seen in persons with this with CSM frequently involve the gray matter, while it less commonly affects the white matter, which is a finding that is consistent with ischemic insult. And it's been shown that the level of the ischemia most likely occurs at the level of impaired microcirculation. Stretch-associated injuries has also been implicated in the pathophysiology, and the narrowing of the spinal canal and abnormal motion seen with cervical spondylotic myelopathy may result in increased strain and shear forces, which can cause localized axonal injury to the cord. All these processes lead to a neuroinflammatory, they trigger a neuroinflammatory responses, leading to a cascade of cellular events causing demyelination of the corticospinal tract, the central gray matter, and loss of interneurons and anterior cell atrophy, anterior horn cell atrophy. It's been found that this problem is most common between C6, C7, and C5, C6 levels. And it's been found that those that are less than 55 years, the most likely implicated problem might be just a prolapse disc, which is described as a soft disc, while in those that are older, there's development of osteophytes, that's the osteophytic bars that narrow the canal, and thickening of the annulus, described as the hard disc. The next slide. This picture shows what we say. Next slide. So this prolapse, which I described, can occur in different stages. The earlier stage is stage 1 is the degeneration, which may basically just involve the changes in the proteoglycans and the dehydration, water content of the disc. And then the second stage, when this becomes weak, the prolapse may occur, and then extrusion occurs when the annulus actually gets ruptured, and then can get sequestered as the disease progresses. Next slide. The symptoms of the clinical manifestation of cervical spondylosis occur quite differently, and it can be syndromic or non-syndromic. For the non-syndromic ones, patient might just, it's been found that neck pain is the most common symptoms, most common symptom of this patient present with. Next slide. Next slide. The neck pain associated with spondylosis often is accompanied by neck stiffness with radiation into the shoulders or the occiput. They may even be chronic or episodic with long episodes of remission, long period of remission. A small amount of this patient may also present with arm, forearm, or hand pain. Next slide. Chronic suborbital headache may occur in this patient and is a condition that is not, poorly understood. The headaches are usually suborbital and may radiate into the base of the neck and the vertex of the skull. Next slide. Radiculopathy can also be a prominent finding and is associated with is a condition that is better understood than the pain and headache that usually occurs with cervical spondylosis. It often affects the 6th and the 7th nerve, which corresponds with the C5, C6, and C6, C7 spondylotic levels. And patients usually present with pain, paresthesia, or weakness, or a combination of these symptoms. The pain is usually in the cervical region and the upper limb, the shoulder, interscapular space region, and at times the pain may even be atypical and may manifest as chest pain or breast pain. This pain is more frequent in patients in the upper limb than in the neck, although it is frequently present in both areas. Next slide. The cervical spondylotic myelopathy is the most common cause of non-traumatic paralysis and tetraparalysis, and the process usually develops insidiously. The high compressive myelopathy, that's between C3 to C5, can present with a syndrome of numb, clumsy hands, characterized by difficulty with writing, loss of manual dexterity, non-specific and diffuse weakness and abnormal sensations. While those that have a lower myelopathy below the C5 typically present with syndrome of weakness, stiffness, proprioceptive loss in the legs. These patients often exhibit signs of spasticity. Next slide. Loss of sphincteric tone, sphincter control, and urinary incontinence are rare. And cervical spondylotic myelopathy significantly affects patients' quality of life, as some patients have even reported depression and being quite anxious, or may even have decreased mobility, which is related to decreased mobility. Next slide. Rarely, dysphagia or airway or dysfunction may occur, and it's been found to be as a result of a large anterior osteophyte that causes mechanical compression of the esophagus or periospheric inflammation. Muscle atrophy can occur in the supraspinatus, infraspinatus, deltoid, triceps, and first dorsal interosseous muscle. Winking of the scapula can occur, especially with C6 or C7 radiculopathy. Next slide. Next slide. Okay, so this findings, the first diagram actually shows a patient that is the Spalding sign, which might be positive in these patients with cervical spondylosis. So it demonstrates the patient, there's usually initial extension, and then the head is flexed towards the side of the pain, and then a gentle pressure is applied, and then the patient reproduces that pain. And then the limit sign, which is usually a patient flexes the neck, and then the pain radiates down the spine and then into the arm. And then the Hoffman sign, where the patient the middle finger is stroked, and then there's flexion, which is shown in that direction of the thumb on the affected sides. Next slide. These circular signs do not often strictly follow the textbook dermatomal charts. Next slide. Next slide. Okay, next slide. Next slide, see.
Hoffman sign.
Next slide, sir. Okay, sorry, hold on. Now, positive results suggest that the pectoralis muscle reflex is another occasional useful test that's been tried. This actually is done by tapping the pectoralis tendon in the deltopectoral groove, which causes adduction and internal rotation of the shoulder if hyperactivity is present. Positive results suggest that compression is in the upper cervical spine, C2 to C4. The jaw jerk, if a patient exhibits diffuse hyperreflexia, the jaw jerk may be helpful. in distinguishing the upper cervical cord compression from the lesions that are above, usually those in the pons and above. So the judge, if the judge is present, may suggest that the lesion is above, you know, and if it's not. So then, next slide. Wasting of the intrinsic muscles of the hand is also a typical finding, and usually a thorough examination of the patient's hand may be revealing. Patient makes a fist and releases it 20 times in 10 seconds. An impairment or clumsiness may be observed and may suggest cervical myelopathy. Finger escape sign may also be present. Next slide. Lower extremity is typically characterized by proximal muscle weakness, and most commonly in the iliopsoas. Patients with spondylotic myelopathy, cervical spondylotic myelopathy may also have stiff spastic gait, especially in the later course of disease. Next slide. Next slide, sir. Now, for the syndromic ones, it could be a transverse lesion syndrome, which is related to Brown-Sequard syndrome, and then could be a central cord syndrome or motor system syndrome, brachyalgia. So for the central cord syndrome, which has been described as man-in-barrel syndrome, there's weakness in the upper, there's more weakness in the upper limb compared to the lower limb, and patient may have varying degrees of sensory manifestations. Motor system syndrome, it typically involves the alpha motor neurons, and then patient might present with features of lower motor neuron findings. Brachyalgia usually involves the pain in the upper arm with any of these core syndromes. Next slide. The differential diagnosis include ambulatory sclerosis, amyotrophic lateral sclerosis, which typically involves lower motor neurons, and patient findings are usually, that of that. But when compared to cervical spondylotic myelopathy, patient would have the neck pain, and then the other findings, which may involve usually the upper motor neuron findings, as seen. Then multiple sclerosis is the demyelinating disease, which occurs in younger patients and has an intermittent. It has a remitting course, and when compared to cervical spondylotic myelopathy, which usually occurs in older patients, those are greater than 55 years, and usually would have a more progressive course or even a stable course. Herniated cervical disc, usually in younger patients, the soft discs that we talked about. And then
you have 5 more minutes, Dr. You have 5 more minutes, okay? Thank you.
Yes, I'm done actually. Intracranial hypotension can be. So thank you for next slide. Thank you.
All right. Thank you very much, Dr. Aka, for that well-researched presentation. We'll be moving on to the next speaker, but before we do that, just want to let us know that we have about 55 participants on the program this evening. And then if you do have any questions, please type them into the chat box. I'll be taking note of them so that at the end of the 2 presentations, we would ask our questions. Okay, so please type into the chat box, all right, if you have any questions. Okay, without wasting time, let's move on to the next presenter. Dr. Chukuma, please share your slide and you can start.
Okay, thank you, moderator. Good afternoon, Prof. Standing on the existing protocol, I'll be continuing the discussion with the management of cervical spondylotic myelopathy. And I'll be doing that using the following outline. Just a brief introduction to what my colleague has said. It has been made clear that cervical spondylotic myelopathy are degenerative changes involving the cervical spine leading to cord compression and also defined clinical syndromes. And this is a cause of significant debility and it's an economic burden. So this needs prompt and detailed clinical evaluation and also neuroimaging in order to make prompt diagnosis and also make appropriate treatment decision. I must say that the management of these patients is multimodal and multidisciplinary, and therefore, for every patient following detailed clinical assessment, treatment must be individualized. This patient's management starts with a detailed clinical history, which is aimed at eliciting all the symptoms and signs that my colleague has mentioned as affects, as regards the motor, the sensory, and also autonomic dysfunction. Then effort is made to identify said risk factors such as trauma and infection, or even lifestyle modification, maybe people that carry heavy loads and cause significant axial loading. We also look for associated comorbidities to be able to assign a Karnofsky performance to the patients in addition to the cervical spondylotic myelopathy they have. Other comorbidities may make them to have a poorer Karnofsky score. So this has to be well ascertained. Then in history taking, we also make effort to look at how this has impaired the patient's daily activity, and some scoring systems have been made available. The Japanese Orthopedic Association score, which has a modified version, the neck disability index, the Nuri grade, and then further histories aimed at reading out the differentials that has been discussed. So examination findings of these patients is as summarized under these tables. We examine the neurology of the upper limb and the lower extremities. Just to summarize, the upper limb can have a mixture of both lower and upper motor finding. The lower motor finding because of the application of the anterior horn cells at the level of the myelopathy, while the upper motor finding are levels below the level of the pathology. So the features is as my colleague has described earlier. Then after history and examination, we now have opportunity to adequately grade this. And Nuri grade is one of the grading systems used for this patient. However, if we look at this grade from 0 to 5, we'll see that this is basically assessing how this condition has affected the patient's gait, ability to walk, and ability to maintain an employment. So it does not really assess the full impact of this disease as relating to the upper limb and also sensory function. So because of this, many researchers have done away with this, and most people now use the modified Japanese Orthopedic Association grading. This is more detailed because it tries to assess all the various functions of the spinal cord and also the various regions. So it assesses the motor, the sensory function, and also the sphincters. So for the upper limb, the motor function is assessed and is given a score of 0 to 1 as displayed. The same is done for the lower limb. And then the sensory system is assessed both for the upper extremity, the lower extremity, and the trunk, and graded 0 to 2 for each and every one of them, depending whether there is a mild, moderate, or severe, depending on whether there is severe, mild sensory deficit or none. And then our effort is also made to assess the degree of sphincteric dysfunction. So this will give us a total score of 0 to 17. And this has further been used to grade myelopathy into mild, moderate, and severe. When a patient scores less than 12, patient is said to have severe, while scores 12 to 14 is said to be moderate myelopathy, and score 15 and above is said to be mild myelopathy. To further manage these patients, neuroimaging is very important, and the imaging commonly done include plain X-ray, magnetic resonance imaging, and also CT scan with or without myelography. X-ray is relatively cheap, and most times it might be the first thing that these patients do.
Now, she get to and person like you come like that. They're not the book brand, they're not the suspect anything.
Hello? X-ray might be the first investigation these patients are likely going to do. So it will be showing us classical features of a cervical spondylosis. However, we must note that one of the most important uses of X-ray in these times that we found ourselves is to assess for instability. As you do a dynamic X-ray to look for any evidence of instability, which will inform the choice of treatments that these patients are going to offer. Another important use of chest X-ray, of plain X-ray, is to assess what we call the Pavlov ratio, which looks at the anterior-posterior diameter of the spinal canal divided by the anterior-posterior diameter of the vertebral body. This is expected to be greater than or equal to 0.8. When it is less than 0.8, it will likely suggest canal stenosis. It can also be used to make several measurements that will give us information on cervical sagittal balance, as you'll see later on in the presentation. Then MRI is the gold standard because it gives us information on the soft tissue. So the state of the disc, the multi-level generative changes, disc herniation, whether it is a central one or whether it also has a lateral component of herniation, the state of the spinal cord and also the exiting nerve roots, and the state of the ligament. So it's the gold standard. In the cord, it also shows us if there are already signal changes within the cord, which may portray poor prognosis. We also know the state of the facet joint, as you can show facet joint effusion and suggest the facet arthropathy. It also helps rule out all the biology of differentials that we have mentioned earlier. The role of CT is basically to define the bony anatomy, and it is the gold standard in the diagnosis of ossified posterior longitudinal ligament. So most of the information we can get from an X-ray, we can as well get them from a CT scan. Another important use of CT is that it is used to take measurements, especially when a fusion technique that will require the use of screws are to be done. CTA is important, especially when doing a laminectomy with lateral muscle. It helps us to study the vertebral artery anatomy. Myelography is usually indicated when MRI is contraindicated, like those with ferromagnetic implants. This image is just to show us how an X-ray of a patient with cervical spondylosis appears. As you can see, this C5-C6-C6 is showing obvious generative changes with osteophytic lipins and also narrowed disc space, and also see osteophytes posteriorly and loss of the normal cervical logosis. These lines are important anytime these patients have been assessed. The anterior and posterior spinal lines, vertebral lines, the spinal laminar line, and the spinous process line. It's important to look at them to make sure that there is no diastasis in the patient. Then this image here is trying to show us the Tog-Pavlov ratio, how it is obtained as earlier described. In CT scan, this is also to show us some of the findings that we may see on CT. This is the axial image. So through here,
do I bring the folder? I've already.
Through here, we can be able to make measurements to know the length of screws that can be used when an anterior approach is being considered, and also to know the thickness of the screws and the length that can be used when a lateral mass screw is being done. This is also showing severe generative changes with loss of cervical lordosis. Here, you can see the hyperdensity behind the body of C2 and C3, which is classical in ossified posterior longitudinal ligament. So this is just showing us the appearance of a CT myelography when MRI is not available. And in this image, you can see the obvious compression by an osteophyte at the level of C7 vertebral body. So MRI is the gold standard. We're able to see the cord, we're able to see the thecal sac and the surrounding CSF. It shows us the disc. So in this patient, we can see the multi-level generative changes, involving both the bone and the disc, and significant compression of the spinal cord and the thecal sac, and associated signal changes within this cord. Axial image here is also helping us to see the sequestered disc here, the disc extrusion here with significant cord compression, giving it somewhat the classical banana sign that may be appreciated in some of these patients. So other investigations that are required in these patients are investigations for optimization and to work up the patient and plan for definitive treatment. So electromyographic studies is basically used to differentiate this from other causes of peripheral neuropathy. Blood investigation, the full blood count to ensure that the HB is adequate and that there is also normal platelet count in view of planned surgery. Even the white blood cell count, rule out any systemic sepsis, which can complicate instrumented procedures. The renal function has to be assessed to be sure it is normal. Clotting profile has to be normal. Patient has to be screened for retroviral hepatitis B and also hepatitis C to ensure that in view of possible transfusion intraoperatively. So blood is grouped and cross-matched. And then these patients are usually elderly. So it's good to have a cardiac workup, chest X-ray, ECG, and 2D echo as indicated, and also cardiology consult when indicated. Other comorbidity screening include the full blood, fasting blood glucose, as some of them may also be diabetic. Now, what are the treatment options for a patient with cervical spondylotic myelopathy? It could be either non-operative or operative. So the indication for non-operative treatment are those with mild myelopathy. That's the modified JOA of 15 to 17. However, when taking this decision, it will be good to bring age into consideration. The very elderly may be better candidates to consider non-operative management or when they have mild myelopathy because of the natural history that has been stated. Then, in the presence of comorbidity for patients that cannot withstand surgery, that have very poor canal sleep, this patient may also be considered for non-operative management. And the options include the use of cervical collar. This helps to reduce the micro trauma caused by the dynamic components, as explained by the previous speaker. Bed rest, lifestyle modification, physical therapy, analgesics, and also cervical traction. All this has been described by many researchers. However, I must say that these options for non-operative management may be the first line of treatment, even when patients are being worked up for operative management. Indications for operative management include those with mild MJOA score of 15 to 17, especially the younger age group, because of the natural history, knowing that this disease is going to progress, and the worse the myelopathy patient has before presentation, the worse the prognosis. Moderate JOA, severe JOA, and also those who were previously planned for non-operative treatment who had progressive disease. The options of treatments could be anterior, posterior, or combined. And anterior approaches could be the anterior cervical discectomy or corpectomy with fusion, or anterior cervical arthroplasty, that's disc replacement, when motion is intended to be preserved at the segment. Posterior approaches could be laminectomy with or without fusion, laminoplasty, and laminoforaminotomy has also been described by some researchers. However, this is ideally fitted for those with a lateral dis herniation causing a foraminal stenosis and nerve root compression. Combined approach is commonly done for those that have combined anterior and posterior compressive pathologies. The anterior approach, the benefits are, which can also stand as the indication, include one, it offers opportunity for direct decompression of anterior compressive pathologies such as disc, osteophytes, and also ossified posterior longitudinal ligaments. And the anterior approach helps to maintain or even correct any cervical malalignment. And then there is reduced post-op pain compared to the posterior approach. However, the drawback is that most of these anterior approach is usually associated with fusion. And because of fusion, the risk of adjacent level disease abides. There is also increased risk of injury to the soft tissue and also the neurovascular structures that are around this area. And it is not ideal for stenosis involving more than 3 levels. For posterior approach, the major benefits and the indication are one, they may not require an implant, that's fusion procedure. And because of that, it's the cost is lower and the risk of adjacent level disease is lower compared to the anterior approach. However, another benefit is a direct decompression of posterior compressive pathology, like the hypertrophied ligamentum flavum that was explained earlier. It can also help in indirect decompression of an anterior compressive pathology, but this is ideal in those with sustained cervical lordosis, so as to give the classical bowstring effect. And it is ideal for those with multi-level or congenital spinal stenosis. The major drawbacks are one, especially those with that have a simple laminectomy. There is risk of cervical malalignment and also deformity. And there may be persistence or progression of an anterior compressive pathology because it's just an indirect decompression, decompressive technique. And also, patients may have more post-operative pain because of the extensive paraspinal muscle dissection that is done during a posterior approach. The key considerations that helps decide which approach is taken for these patients are as listed in the slides shown. One is the extent of canal stenosis, that's the number of levels involved. The higher the number of levels involved, then the tendency to choose a posterior approach increases. As stated earlier, once it's greater than 3, or people with congenitally narrowed canal, where you might need decompression of up to 6 or up to 4 or more levels, then a posterior approach is required. Location of the pathology: anteriorly compressive pathologies are better approached anteriorly, while posteriorly located pathology are better approached posteriorly. The sagittal balance of the cervical spine must be considered. This is ascertained from a plain radiograph as shown. The first is the C2, C7 curve angle, which is derived by drawing a line that runs through the lower end plate of C2 and C7, and then drawing other lines that run perpendicular from the initial lines. The point where they bisect, the angle it makes, is the C2, C7 curve angle, which has been said to be between 20 to 35 degrees. So the lesser this angle becomes, that means the cervical lordosis is being lost. That will make us to tilt more to an anterior approach as opposed to a posterior approach. The C2, C7 sagittal vertical balance, from the center of the odontoid of C2, a straight line is drawn downwards, and then from the posterior inferior end plates of C7, a horizontal line is drawn to meet the previously drawn line. Now, the distance from this posterior inferior part of the end plate to this has to be less than 4 cm for you to consider posterior approach. If it is more than that, then you are better off sticking with anterior approach only. T1 slope is also a line drawn, this inferior line at the inferior end plate, and then a horizontal bar, the angle they make. The higher this T1 slope, the more likely a patient is going to benefit from an anterior procedure. Another thing to consider is the K-line. This K-line initially was used in treatment decision for patients that have ossified posterior longitudinal ligament, and usually measured using a lateral radiograph, a lateral plane radiograph. So patients are usually classified either as K negative or K positive. K negative is when a line that is drawn from the center of the canal at the level of C2 up to the center of the canal at the level of C7. And then you now check whether the compressive pathology, whether it gets up to or gets beyond that line. That is said to be K negative. And patients like this are better handled with an anterior approach, because posterior approach will worsen the kyphosis these patients will have. Why K positive is when the pathology remains anterior to this K line. So modified K line is that an MRI can now be used to also ascertain this, as illustrated there. You can see the compressive pathology is obviously touching and beyond this line. So that is said to be K negative. And this patient is better off with an anterior approach, as posterior approach will worsen this pre-existing kyphosis. Then if there is also instability, that means this patient will benefit from a fusion procedure. The goals of surgery: 1, to relieve cord compression, to halt neurological deterioration, to ensure that there is spinal stability, and to correct or maintain cervical alignment. The surgical anatomy, this has been explained earlier. I'll just run through it briefly. This is just to show us the avascular plane from here between the sternocleidomastoid and the carotid sheath and its content laterally, and then the strap muscle, trachea, and oesophagus medially. So through this avascular plane, we're able to assess this anterior part of the vertebral body. And then posteriorly, we go through this avascular plane also, while continuous subperiosteal to strip this muscle, and we can be able to reach the spinal process and the lamina. So important surgical consideration: informed consent must be obtained. These patients must be well counseled on the goal of surgery, as we stated earlier. They must understand the details of the procedure, the risk and the complications that are associated with this procedure, and then the alternatives to treatment, non-operative, posterior or anterior approach. All this has to be explained, and the expected outcome as regards improvement in neurology. Then it is good to have a CM, which will help for intraoperative localization, an operating microscope, neurophysiology monitoring, and also implants or autologous bone graft has to be planned. The anesthetic consideration, the procedure is usually done under general anesthesia with cupped endotracheal tube. The intubation of this patient preferably should be done in neutral position to eliminate the dynamic component of cord injury. So a video of fiber optic laryngoscopy will be of help. The target MAP should be more than 80 millimeters to prevent intraoperative cord ischemia, which can be a cause of early neurological deterioration post-op. Then patients should receive prophylactic antibiotics. To give a synopsis of some of the approaches, the anterior approach is as shown. The patient is positioned supine with the head elevated 20 to 30 degrees from the trunk. Sorry, from the trunk as demonstrated, the arm tucked by the side of the scapula so as to allow extension of the neck, and then the head, the occiput is allowed to rest on a donut rest. The knee is flexed and the pressure points are padded. Test stockings applied. A urinary catheter passed as for monitoring of urine outputs. After that is done and the surgeons have scrubbed, the operation site is prepared. From the chin, the neck up to the chest is prepared, and also the iliac crest, excuse me, the iliac crest is also prepared when it is going to be used to harvest the bone. After this localization is done, this will be done clinically using important landmark, the cricoid cartilage, which is at the level of C6, or the thyroid cartilage at level of C4, C5, or intraoperative fluoroscopy can be used, or even neuronavigation. So the choice of incision, these are the incisions that could be used to assess the anterior spine. This one with an arrow pointing downwards is depicting the midline, while this is a transverse skin crease incision, which offers better cosmesis. And then this is the oblique incision along the medial border of the sternocleidomastoid, which may help you to expose more levels. So when this incision is made, we'll get to the platysma, and then the platysma is also incised transversely and then undermined and held with self-retaining retractor. The investing fascia is now opened along the medial border of the sternocleidomastoid, and blunt dissection is continued as shown here, that's between the sternocleidomastoid and the carotid shield and its content laterally, the esophagus, the trachea medially, until the prevertebral fascia is reached. A shorted monopolar diatemy is now used to incise it at the midline, and also to strip the longus colli out of the midline and laterally, but care has to be taken to avoid going through laterally so that the sympathetic chain will not be damaged. Once this is done, the cloward retractor is placed as shown, sideways with the serrated blade positioned laterally and the smooth blade positioned medially. And then it can also be placed in the cephalocaudal direction to have a good exposure. After that is done, it's good to always ascertain that we are at the right level. So a bionated needle, as shown here, is used, bionated to prevent it from entering the canal and causing cord injury. So this is used, inserted at the suspected level, and imaging is taken to confirm that we are at the right level. Once this is done, the Casper retractor pins are positioned as shown, and then using the retracting device we're able to retract and open up the disc space. This singular action also helps to correct kyphosis or loss of cervical nodosis. So this is the retracting device that has been inserted into the retractor pins demonstrated here. Now, after this is done, then the disc space is now handled using a size 15 blade to do anelotomy, and then with the aid of pituitary rongeur and curette, the disc is removed as indicated. And then after this is done, an operating microscope can be brought in once the inner part of this disc removal is being done, so as to prevent injury to the thecal sac. A nerve hook can be used to lift up the posterior longitudinal ligament so that it can be removed without injuring the thecal sac to prevent the CSF leak. Once the disc has been removed, it's good to inspect for osteophytes that are still causing cord compression, and this can be easily removed using a kerosene punch. After this is done and the disc space has been well cleared, Then the end plates are prepared as shown here. It can be done with a drill or even a curette so as to expose healthy cancellous bones and allow for better fusion. At this stage, whether it's the implant or the autologous bone graft is now put in place, care taking not to enter the spinal canal and reestablish a cord compression. After this is done, then the appropriate plates and screws are applied, with the screw usually pointing superiorly and medially. At the end of the surgery, an intraoperative fluoroscopy is done to show proper positioning of the implant. So this is usually what is done for an anterior approach, classically for anterior cervical discectomy with fusion. In laminectomy, briefly, the patient is usually positioned prone and head can be held in a Mayfield clamp. Head can be held in a head-filled clamp, making sure that the patient is lying maybe in a Montreal mattress or Wilson frame to prevent, to allow space to prevent intra-abdominal pressure. Then the incision, after the patient has been prepped, the incision is usually in the midline to stay in the midline avascular plane. So reaching the spinous processes, subperiosteal dissection is continued to expose the spinous process and also the lamina. And with the use of a drill and a kerosene punch, the lamina is removed to expose the ligamentum flavum, which is also removed, and then to make sure that the cord is well decompressed. The neural foramen are also inspected to know if there will be need for foraminotomy. Once this is done and the cord is well decompressed, then the wound is closed. However, if there is evidence of instability, or when a long segment decompression is done and future instability or cervical alignment is considered, then a lateral mass screw can be placed as shown here. Usually, the screws are placed angled 30 degrees laterally and then 10 to 15 degrees cephalad. Laminoplasty is done to, we are just trying to reduce removal of the posterior supporting elements. So it could be either of the open door type or the double door laminoplasty. So in the open door type, after we've assessed the spinous process and the lamina as described in laminectomy, one side of the lamina is drilled open as shown here, while the other side is drilled until the inner cortex is reached. It is not opened completely as depicted here. After this is done, a lateral force is applied so as this place now serves as a hinge that will allow this lamina to open. As it's opened here, it has increased the space of the spinal canal and thereby helping decompress the canal. The yellow ligament is now removed with the aid of a kerosene punch. The neural foramen is also ascertained to know if a foraminotomy is indicated. So this space is now maintained either with a suture tied here and anchored to the facet capsule here, or with plates and screw. While in the double door approach, instead of opening it completely at one side, we try to drill and then retain the inner cortex on both sides. And then the spinous process is now divided in the midline, and the lateral forces are applied on both sides and to open up the spinal canal. And then using a strut graft or even a plates and screw, the space can now be held. So this way, by so doing, we've been able to increase the diameter of the canal and therefore reduce compression. The post-operative management.
Try to round up now, okay? Thank you.
Okay, thank you. Post-operative management of this patient is as shown here. The complications could be general or specific. General complications is as listed, and then other specific complications for ACDF and then posterior approach and fusion are all as indicated. The prognosis, the determinants are: one, the age of the patient. The older the patient, the poorer the outcome. The more the duration of the symptom, the poorer the outcome. And the more severe the myelopathy, the poorer the outcome. It has been found by some researchers that outcome at 6 months is not significantly different to the outcome at 1 year. So at 6 months, we can predict that a patient has plateaued in terms of recovery. Patients has to be followed up for long because neurological deterioration can occur even from progressive disease. In conclusion, Cervical spondylotic myelopathy is a global health condition with significant debility and economic burden. Prompt diagnosis is key, and management of these patients is multidisciplinary and multimodal. Surgery still plays a pivotal role in management of these patients. Thank you. These are our references. Thank you for listening.
Wow, wonderful. Thank you so very much for the presentation. I'm sure everyone will agree with me that we have had a very good lecture from our two presenters today. We would quickly look through the questions that have been posed before we call on our faculty to give us surgical peels and words of wisdom. So let me just give us the questions. The first question was for this JOA grading, that's a Japanese Orthopedic Association grading. How is it adapted to our locality to assess a village man or woman who does not use cutlery to eat? I think Dr. Chukuma, you can answer that question.
Okay, thank you. I think we can still adapt it based on, because I think we are trying to assess a fine motor functions. So the common things we used to eat, spoon, some of them, once they have this problem, they can't even feed themselves. So we can still use it to adapt to our locality, whether the person is having significant difficulty in using it, mild difficulty, or whether a person cannot be able to feed himself at all. So because in the Japanese own, they use chopping stick, which is what they use locally. So locally here, we adapt with what we commonly used to eat. Spoon, even our hands when we are taking swallow, can this person be able to mold the swallows appropriately? Thank you.
Exactly. And some people will talk about being able to button your shirt by yourself. You know, that's another thing you can use to check fine motor hand use. All right, the second question is, what's the clinical significance of the Tog-Pavlov ratio? The clinical significance of the Tog-Pavlov ratio.
The Tog-Pavlov ratio is actually used to determine congenital canal stenosis. So when you get less than or equal less than 0.8, it shows that apart from the degenerative process, patient has pre-existing congenital canal stenosis.
All right, thank you very much. The next question is
to help you in deciding the choice of approach, as canal stenosis is likely long segments and patient may benefit from a posterior approach.
Okay, thank you very much. The next question is, how do you differentiate CSM from multiple sclerosis?
Okay, I think my colleague said that earlier. Multiple sclerosis, is likely to occur, can be seen both in the younger age group, and it has remitting and relapsing episodes. Unlike cervical spondylotic myelopathy that is commoner in the older age groups and have a progressive course. Then multiple sclerosis is also not confined to the cervical cord. It can also involve the brain, and the patient can manifest other CNS features aside what we've described so far. And also on imaging, you can see the T2 signal changes in the cord, also in the brain. So those are the ways that we can use to differentiate them. Thank you.
Thank you very much. There are quite a lot of questions, and I may have to jump a few. Someone asked, how many levels the stemmed long segment from?
Hello? Hello, can I be heard?
Did you get the question? Did you get the question?
Your line is breaking a little, ma.
Okay, the question is, can you hear me now?
Yes, I can hear you.
Yes, the question is, how many levels is stemmed long segment from the posterior approach warranting instrumentation?
Okay. I honestly I didn't really I didn't, but some studies I saw, when they are once they are doing up to 3 or more, they start considering instrumented fusion. But our faculty will help us on that. Thank you.
Yes, you're right. Most times, once you are having 3 levels or more, you would want to consider instrumentation. And like you said, our faculty will help with that. There are many other questions. I think let me just ask this one. Someone asked, what is white coat syndrome? And how do you handle it? White coat syndrome, and how do you handle it?
Okay, please, I think I'll need help with that one. Thank you. Hello, did you hear me?
Yes,
Hello?
yes. Sorry, I didn't know I was muted again. Yes, well, I can hear you. So we'll discuss that later on. What is white coat syndrome? We'll discuss it later on. Somebody asked, I'm just trying to quickly read through all the questions that I have here. Someone asked, when do you say ligamentum flavum is hypertrophied? And when will stabilization be necessary after laminectomy? I think that one has already been answered. When you have multiple levels of laminectomy being done, you would need to stabilize. But when you say ligamentum flavum is hypertrophied, can you hear me?
Yes, I can hear you.
Good. So when do you say ligamentum flavum is hypertrophied?
Okay, I'm not sure I've come across any measurements, but I think we commonly observe that in our radiological reviews. So please, I also need help if there's any value to that. Thank you.
Okay, wonderful. All right. Let me just see if there are any other questions that we can. Okay, somebody asked if, with respect to the multiple sclerosis, if there is a role for CSF analysis to differentiate multiple sclerosis from CSM. He also asked, why are you specific on post-op C5 myelopathy? And I think the last question is, what is the usual cause of patient's deterioration, pathogenesis, and prevention? This is a very wide question. I don't know if we should take that. But let me ask this one question. Someone asked, what is your opinion about tandem CSM and lumbar canal stenosis? Can you answer that one, Dr. Chukuma, please? What is your opinion about tandem CSM and lumbar canal?
Okay, thank you, ma. In my opinion, the standard teaching is that a patient that has a higher cord compressive pathology, it should be attended to first before a lower pathology. So I'll tend to attend to the CSM first before the lumbar pathology. However, the caveat there is it also depends on which one is causing more symptom and worry to the patient. So one of my trainers here also, if he observes that the lumbar is what is more symptomatic compared to the CSM, he does the lumbar, while continue the patient on conservative care of the CSM, and then later that will be done. But standard is do CSM first, then follow up with the lumbar. Thank you.
Okay, very good. Thank you very much. But my question to you now would be, but why do you have to do the cervical first? What is the rationale behind doing the cervical first?
Okay, the rationale behind doing the cervical first is that it helps you to really assess the degree of neurology that is as a result of the lumbar compression. because doing the lumbar first, when there is a superior compressive pathology, it might as well be what is responsible for some of the symptoms patients may be complaining of. So I think it's better to do the superior compressive pathology to now better assess the degree of neurology in the lumbar area and then know the treatment to administer. Thank you.
All right, very good. Thank you for all your answers to the questions. Also for this in particular, this question on cervical and lumbar. It's also because, when you're going to do the lumbar spine, you're going to turn the patient over to do it from the posterior approach. And there can be issues with worsening the patient's clinical state if the cervical spine is not well stabilized during your positioning of the patient. So it's always advisable to try to do the cervical first, especially when it is symptomatic, before you go on to do the lumbar spine. But at this point, we have spent a lot of time, and I think it is time for us to welcome our faculty for the day to give us his words of wisdom on cervical spondylotic myelopathy. So this evening, we have with us a very senior mentor and trainer of many years' experience in the person of Professor Wilfred Mizwe, consultant neurosurgeon in the Enugu Neurosurgery schools. So thank you very much, Professor Mizwe, for joining us this evening. Please, would like to have your words of wisdom on management of cervical spondylotic myelopathy. You're welcome, sir. Professor Mizwe. Hello. Hello.
Can you hear me?
Now we can hear you, sir. Thank you so much, sir. Hello, Prof. We can't hear you again. I don't know if...
Can you hear again?
Now we can hear you, sir.
I don't know what's going on there. Okay.
Yes, we can hear you now, sir.
All right. All
yes,
right.
Sir.
So apologies. I was trying to unmute and it was giving me trouble. I said that this has been a very interesting discussion. I think the two discussants did quite a good job on their research and presentation. And I think the questions, most of the questions were really relevant and on spot and well taken. The thing about chronic cervical myelopathy is that it's a very common problem, more common than people actually understand. A lot of the patients who present with chronic cervical myelopathy present very late, unfortunately. And that's why we think there are very few. There are a lot of people managing outside with the condition that should be seen in hospital. And unfortunately, it happens in elderly people, some of whom are no longer able to have enough funding to treat themselves. And they just keep struggling. But it is a very, very treatable condition. If you catch the person early, you shouldn't, in as much as we've discussed the indications for surgery, we shouldn't allow patients who have significant myelopathy to continue on that line, because once you deteriorate, it's very difficult to reverse. When they have lost significant function, it's very difficult to reverse. And some of it, and because it occurs in elderly patients who are prone to falls, once they fall, a minor injury following a fall tips them over into severe cord injury. And it might just be a minor tap of the head against the door and anything, and then they just go off and develop a severe type of myelopathy. Now, I think the person who presented the pathophysiology mentioned that this commonly happens around the central cord. So they tend to have a type of central cord syndrome. And when they present, they have more difficulty with using their upper limbs, and mobility is very, very poor. So these patients really never recover very well. When they come at that stage, the best you can do, obviously, is not to jump in and start operating upon them. Because at that stage, if you operate on them, in most cases, they deteriorate. So the best thing is to allow them, give them some window of opportunity to recover as much function as possible before you go and then remove the compressing elements and free the cord. But if you want to do it in the acute phase, when there's some degree of edema and some degree of vascular insufficiency around that cord, they tend to deteriorate when you finish. So remember that in such cases, you have to weigh your timing of intervention when they have already come with their central cord syndrome. These are some of the small things you need to be aware of. And then you've talked about approaches to posterior and anterior approaches. And I think he has covered most of the grounds, unless there's something you don't understand. I think he's covered most of the points that are necessary for you to cover if you're doing either approach. I don't know what else I need to let you know. But otherwise, the lectures were well taken. Are there questions that you want me to address? Because I don't want to start repeating the whole lectures that they've given.
Yes, Prof. Thank you. Yeah. Thank you very much for these PLs that you have given us. I think one of the questions is somebody asked about white cord syndrome.
I'm not quite sure what he meant by white cord syndrome. Is it an edematous cord, or is it a cord where that's ischemia? In which case, the patient presents with a cord that appears white on MRI. That's due to ischemic change within the cord. So when the cord has become ischemic, it appears white. And that's why probably what is called a white cord syndrome. I don't know that it's normally called a white cord syndrome. But it's an ischemic change due to persistent pressure. And once it has happened, once it appears on MRI, then it's evidence that that cord is significantly compromised or damaged. And if you're going to operate on such a patient, you will need to counsel the patient carefully, because the outcome is not necessarily going to be very good. These changes, which are quite often common in very severe myelopathies. Once you see them, you alert the patient that he may not recover all the function that he has lost, and that the main goal of your surgery will then be to prevent him from getting worse, rather than to get him to recover everything. So such patients are actually the things we need to avoid when we talk about myelopathy. When you see a patient who has myelopathy early, the idea is to treat the person, because before he reaches the stage when you have cord ischemia and when they present with cord signal changes inside. It's occasionally, it's not usually as white as when there are ischemic cord changes, but edema can also appear slightly whitish. But the typical white cord appearing on MRI scans are due to ischemic changes, and are due to, they're normally called cord signal changes of myelopathy. Maybe they've given it a simpler name, which is white cord. It actually describes it very well, because it appears white. But if the question is a different thing, I don't know about any other white cord that is giving a syndrome.
Thank you very much, sir. I think you have thoroughly dealt with that. Thank you very much, sir. We appreciate you for the insight you have given us with regards to the management of cervical spondylotic myelopathy. I want to also use this opportunity to thank everybody for being a part of the webinar tonight. We have had a number of neurosurgeons with us. Young neurosurgeons are here. And then I think we also have some neurosurgeons from outside Nigeria on this webinar. I can see Dr. Hugh and Dr. Kitungu, Peter Kitungu. They are here. You're welcome. Thank you for joining us this evening. For our young neurosurgeons, Dr. Ghana is here, Dr. Aliyu Koko, Dr. Jolayemi, Dr. Kufi, Dr. Samaila Timothy. Thank you everyone for joining with us tonight. Thank you very much, Professor Mizwe. We really, really appreciate your insight on this topic today. And I want to believe that everyone has learned something tonight, and it will be helpful for us in our evaluation for patients when we see them in the clinic moving forward. Like Prof has said, it's a very common condition. So let's let our antennas be up when we see patients coming to us with gait issues and fine motor movement issues in their hands. Thank you very much. I want to thank everyone for joining in this evening. The Young Nigerian Neurosurgeons Forum chair is busy in the theater, although he's on this webinar, but he's scrubbed at the moment. That's why he's not been able to talk with us on this webinar. So on his behalf, I want to remind all of us that this webinar is held every last Friday of the month. And so our next webinar will be in October 25. Let's watch out for the announcements and prepare to join in. And also, please remember to register for the upcoming NANS conference coming up next month in Ibadan, October 21st to 23rd. And for the young neurosurgeons here, please submit your abstracts. There will be a Young Nigerian Neurosurgeons Forum session at the program. Please don't miss it. And I want to remind us that there is a Jeff Interlarger scholarship for the top 5 oral presentations at the NANS conference this year. And the benefit of this scholarship is sponsorship to the next CANS Congress holding in DRC Congo in November. So please, let's make good use of this opportunity. And so with this, I would like to bring this meeting to a close and to thank everybody once again for being a part of the webinar. Thank you so much, Dr. Adeboye and team. Thank you so much for always organizing a refreshing webinar for us.
Thank you very much. Bye.
All right, thank you. Oh, and Dr. Adros from Somalia, thank you so much for talking to us about the white cord syndrome. I can see you have sent a link to an article on it. So please, young neurosurgeons, please just click on that link so that you can read more job on talking about what it is and how it is important in the management of patients. All right. Thank you, everybody. Thank you for joining in and see you again next month.
Thank you. Bye.
Thank you.
Thank
Bye.
you so much. Bye.
Bye. Thank you, Dr. Hevle Kuya, for coming.